and surveillance, act as a resource for all the clinical and non-clinical staff, reviews IPC practices and ensures adherence to IPC principles. So on-the-job training is very much focused on, because as you're seeing something, so you need to actually be correcting it if it needs to be corrected, or complementing if it is being done correctly. Remembering a lot of our staff are just in the COVID time, just functioning on just go, and they need to be encouraged and to be complimented on jobs being well done. The IPC practitioner also compiles appropriate action plans with respect to IPC. He is responsible, or he, for compiling relevant reports required by the healthcare facility, the Department of Health, or the WHO, and coordinates the committee meetings and other relevant meetings, and assists in reviewing and developing policies. So I just wanted to give that as a bit of a background, because if you know all of what the IPC practitioner needs to be doing and an IPC program, then you will understand the structuring of a IPC committee and its members that need to be initiated. So the Infection Prevention Control Committee is made up of administrative heads from most of the units or divisions that have a direct or indirect influence on infection control. And this pretty much covers your whole hospital or your healthcare facility wherever you are working. Each healthcare facility may make up its own committee structure. So depending on how big or how small your facility is, depends on how many people you will have on that committee. And this is where also the IPC committee may share a platform with your quality assurance members and your occupational health and safety members. But at all times, just to ensure that your infection control matters are being addressed as well, not just focusing on safety and not just focusing on quality management. The non-clinical staff members may include your pharmacist, your housekeeping supervisor, your hospital engineer or technical department, your sterile services manager, food and catering manager, healthcare waste manager, and your laundry manager. The clinical staff members will include your infection control manager or specialist or coordinator, who becomes the chairperson of the committee. The patient safety manager or quality manager may be there. You have a microbiologist or clinician. They might not physically be at every meeting, but they definitely can be contacted whenever a situation arises and clarity is required. Your hospital management representative, there must be someone from hospital management, and that can also be the nurse manager or the deputy nurse manager. And then you have all your unit managers or nurse managers. We call them unit managers in my previous hospital, from all nursing units and associated departments. So these will include your operating theatre, your ICUs, your neonatal units, your maternity and your labour wards, your IPC link nurse. I'm sure there are many facilities out there that do have link nurses in their wards, and they are a critical part of actually being a member of the IPC committee. Your clinical facilitator or learning and development facilitator, otherwise your training department, is a good person to have on board. And then your occupational health practitioner. So what are the responsibilities of a IPC committee? They're there for effective implementation of the IPC program. They must ensure compliance to IPC policies. Now we know that we've got national policies and you've got provincial policies. And then the hospital itself has its own policies that need to be adhered to. And they may have addendums in light of either the national policy or the provincial policy. They need to introduce and ensure the implementation of all new policies. And this is very important. Often we found that there's a new policy that you just have to actually run with and put in place, but there actually hasn't been any training or any introduction to this policy. And then some of the hospital is carrying out the policy and the other part of the hospital is not. And that becomes a bit confusing for the staff at the end of the day. The committee must attend as many IPC-related meetings as what they can. They must provide feedback on action plans with respect to HAIs, which is your healthcare-associated infections, surveillance, and outbreaks. And they provide feedback and action plans with respect to audits that were carried out on your hand hygiene compliance, your bundle compliance, which time back was called Best Care Always bundles, your healthcare risk waste, your environmental cleaning and disinfection registers. So feedback needs to be given on those platforms as well. They identify trends and risks and implement the necessary interventions, compile and implement IPC training programs together with their training department spoken of earlier, ensuring that in-service training is taking place, and this in turn then enhances self-development. We are very keen to ensure that everyone improves themselves at the end of the day in attending any training sessions that is relevant to the area that they are working in. And across all the platforms, infection control remains a critical area for training. Discuss the related IPC topics and epidemiological trends. And here the NICD provides the communique, the information brochure that we all receive, which covers many of those aspects. So we do tend to know what is happening through the country and the world. The committee must inform the hospital management of any issues identified with the corrective actions taken. So they don't always want to know just what the problem was, they want to know what you did about the problem. And sometimes they need to be consulted as you are trying to solve areas that might actually need their input as well. And then address procurement issues. How often do we also see that a new product has arrived in your facility and it's not very user-friendly or nobody knows of it? Those are issues that can be discussed at the IPC committee meetings. So the actual meeting, the IPC manager and her immediate team, which could be the microbiologist, the hospital manager, or the clinician who identifies an area that needs to be addressed at the next meeting, they will draw up an agenda covering the most important matters. Meetings can be held monthly, every second month, or else eventually, once it's all established and up and running, can be run every quarter. In my previous healthcare facility, we had monthly meetings. We just found, especially during COVID, there was just so many things happening and changing all of the time. And that's when we resorted to the Zoom meeting like we are doing now, and not the actual physically meeting around the boardroom table. Carrying on with regard to the particular meeting, clear minutes needs to be taken and kept, ensuring the development of the IPC progresses based on local needs. So whatever was discussed around that table, you need to have clear minutes so that they can take that to their units where they've come from and they can disseminate what was discussed. The record of these minutes must be held centrally so that they can be inspected if needed. We have governing bodies like SASA and the DOH who come and carry out audits, and they want to see that the minutes have been disseminated and people have understood and signed that they have read those minutes. The IPC committee quorum is when there's 50% of the core members must be present. This can be quite challenging at some time because no decision can be made if the quorum is not met. So your quorum must have at least the IPC manager the hospital manager representative, and 50% of the unit managers and the linked nurses attending. Recently, we did not have a meeting because we did not have a quorum, and that was due to just the hospital being very busy and not everyone able to attend at that point in time. So you need to be flexible. If your meeting can't happen right then when it was actually programmed for or tabled for, then you need to push it out and you need to say, okay, we're going to postpone it and then meet at the next week or within 10 days of the actual meeting. It's just a good time frame. Sorry. So your agenda for these meetings may include, and I've listed every area possible, but it also, as we said earlier in the presentation, it depends on the size of your hospital and the number of people that you have in the specific departments. So at these meetings, the agenda can include the discussion on your healthcare associated rates, which would be your SSRs, which is your surgical site infections, any device-related infections, so that is your catheter-associated urinary tract infections, your central line bloodstream infections, your ventilation-associated pneumonias. We can discuss outbreaks and you give feedbacks on the investigations if you had an outbreak. Surveillance is very important when you're looking at your prominent organisms that are popping up in your ICUs perhaps, or in a particular unit where your multi-drug resistant organisms are there and you are needing to isolate your patients. So surveillance is very important to ensure that you are complying and managing those multi-drug resistant organisms. Hand hygiene compliance can be discussed and how to improve practice. Your bundle compliance, that's checking on your VAPs and your CAUTIs and your CLABSIs and SSRs. Audit feedback and environmental cleaning of nursing units and ancillary departments. Here, this is very important as well, because if you find that there's a challenge in the cleaning processes of your units, then it needs to be discussed at the meeting so that the relevant parties can take note and action plans can be initiated. If you have a pharmacy on site, then the pharmacist can discuss pharmacy issues. And here, some hospitals carry out audits of the prescription charts, the signing and the dosing. Very important, because we know that all prescription charts have to be signed by the doctor. All telephonic prescriptions need to be signed the moment that the doctor is able to come sign it. I think there's a turnaround time of 24 hours. The dosing of the antibiotic particularly needs to be correct, and the pharmacy is a good place where they will check on that dosing if it is correct according to the weight of the patient and according to the procedure that has been carried out on the patients. They also can discuss your antimicrobial usage, your prophylactically treatments and and your extended use. Your occupational health risk. Here, those sisters, if you have a particular person, can discuss the recent needle stick injuries, any splash injuries that occurred. They are involved with any post-exposure prophylaxis for their staff if they've been exposed to a particular disease or infection. I'm thinking of pertussis, which is your whooping cough. The nursing staff need to receive prophylaxis. Your PPE compliance and relevant training, they can be drawn into that area as well, because at the end of the day, we are trying to protect our staff to ensure that they are wearing the correct PPE at all times, and particularly now in the last while with COVID. Training aspects can be discussed with respect to infection control, and the training department plays a very big role in those areas. your quality improvement projects that can be discussed if there's a particular unit carrying out a particular project, like managing waste or giving of injections and how they dispose of the needle. Areas like that where projects can actually improve practice. And then there can be a time slot for COVID information. And like we said earlier, there's been lots of changes, people having to think on their feet at that point in time. What must I do? How must I do? And the infection control can always be giving the guidance in this respect. And then if there's any presentations that need to be presented, this is a good platform where training presentations can take place. Previously, we've had invited speakers to come and talk on a particular subject. And that's also just assist in building up the camaraderie at an infection control meeting, because we need to make sure that the interest and the topics are relevant for that time. So the actual meeting, we are to keep short, I'll say entertaining and to the point. There's nothing more than looking around the room and there's some people that are a bit dozing off. I sure hope you're not dozing off now while listening to me. Keep to the agenda and the allotted time. That's very important. Time is precious and we don't need to waste people's time by discussing irrelevant topics when we are just focusing on infection control. Attendance register and apologies must be noted. Refer to the previous minutes of the meeting for comments and feedback, because that's a very important area that must be covered. Begin with the agenda and allow for discussion and feedback after each point. And this can also be timed and made sure that people are actually doing this, that they are keeping to the time. Close the meeting by highlighting the most important areas focused on and inform attendees of the next meeting date. And I've just put here in italics minutes of meeting, the attendance register, the meeting venue and or electronic platform must be forwarded or sent timelessly to all members and other stakeholders. That pre-planning,
sorry, Michelle.
notice of attendance and required feedback. I'm listening.
Can we please mute our microphones so that we can hear Michelle's presentation? One of our participants has got his microphone on. Can you please mute it? Thank you.
Okay, I'll just repeat the last 2-3 sentences there. I'm saying begin with when you start your meeting, begin with the agenda and allow for discussion and feedback after each point. Close the meeting by highlighting most important areas to be focused on and inform attendees of the next meeting date. And in italics here, I've just written the minutes of the meeting, the attendance register, the meeting venue and or electronic platform must be forwarded and sent timelessly to all members and other stakeholders so that they can pre-plan, have a notice of that they're going to attend, and if feedback is required, that they can prep themselves, that they actually present and are ready to give that feedback. It is a bit tricky at times. I know I've fallen short trying to get those minutes of meeting out timelessly for the next session. But if you can manage it effectively, then that will be awesome. With regard to budget, this is a very difficult one to determine because most budgets are managed by the finance department of the hospital, or if you belong to a bigger hospital group, then it's determined by that group, dependent on the provincial or the district level or the national level. So funding for infection control may fall under the, I won't say the bigger part of finance, but they need to ensure that salaries are there for a dedicated IPC staff member, that if they are requiring research for data collection and report writing, that there is some finance for that. Training material, that's very costly. We do know that most training is budgeted a whole year beforehand in most areas, and only a certain amount of training can take place because it costs. It costs for presenters to be paid, it costs for the material to be printed and given out to the people attending, and also actual money for attending any conferences that we have. We know that ICANN has a conference, there's FITSA, there's ICSA, there's African Network. Everyone has conferences that people would like to attend, but that all costs money at the end of the day. So it can be a bit difficult just trying to say how much must be made available. I think it depends on the resource of that particular healthcare facility and their management team. And I think if the IPC practitioner, I want to say, can make her voice known and heard for going forward and for improving practices in her particular or his particular hospital, then there may well be funds set aside. And remembering, if we are following good infection control principles, many of these funds can be recovered by the reduction of any healthcare associated infection and improve procurement practices of PPE and other areas like your solutions, your cleaning materials, your building, your water, your electricity. If all those principles are adhered to, then there may well be money to spend on other areas if we just maintain our basic infection control practices. So in conclusion, the IPC committees must be active and the members to be accountable for the areas that they serve. And then I just of late have just enjoyed going through and reading up on the multimodal improvement strategies to implement IPC practices, because it just helps facilitate the processes involving and engaging with various stakeholders, defining allocated responsibilities, and thus ensuring commitment in sustaining the IPC program of your institution. And here we talk about build it, which is your systems change, teach it, it's your training and your education, check it, it's your monitoring of your institution and the IPC processes, tell it, it's the reminders and the communication. I think we know through COVID that communication was one of the biggest issues, or not issues, areas that was needed so that we could all be practicing the same things throughout the world. And then live it, your culture changed. Just a lot of infection control practitioners out there, I want to say, breathe it as well. We just want everyone just to be doing the right thing all of the time so that we can just ensure that IPC principles are met and practiced so that we don't all get affected or infected by any infectious diseases, infectious organisms, and viruses at the moment. So if I can just leave that note with everyone, that would be great. So I just want to show you my references, and then just to acknowledge Prof. Mehta, Anna, and Mediclinic South Africa, where I previously worked, for all their help and education through my time in infection control. Thank you. That's me.
Thank you so much, Michelle, for that comprehensive, insightful presentation, which concretizes actually the need for infection prevention control structures with defined TORs and relevant stakeholders so that we can effectively manage and prevent infections within our healthcare facilities. Thank you so much for that presentation. And moving on with our program, I would like to introduce Evelyn Wesangula. Evelyn is a pharmacist who mastered in tropical infectious diseases, and she heads the Patient Safety Division at the Ministry of Health in Kenya, which has successfully championed the development of the National Policy and Action Plan and accompanying strategies for antimicrobial resistance in Kenya. She's also been key in the implementation of infection prevention and control, interventions, AMR surveillance activities, and awareness programs at national level in Kenya for over 10 years. Evelyn is committed to overcoming barriers, working with partners within and from outside her country to sustain changes which reduce the burden of AMR in Kenya. And Evelyn today will also be taking us through the steps of setting up and operationalizing infection prevention and control committees, but she'll be looking at it from a national level in the context of outbreak, of course, taking into consideration COVID-19 and Ebola. And she'll also be looking at it around healthcare associated infections. Thank you so much. Over to you, Evelyn.
Thank you very much. Good afternoon, good evening, good morning, everyone. I hope you can all be able to see the presentation that I have just shared. And I want to appreciate the opportunity just to be able to share with you experiences from Kenya in setting up and operationalizing IPC committees at the facility level, and really looking at this from the broader coordination structures from the national level to the regional levels, right to the facility where a lot of these actions are implemented. And I want to really thank Michelle for a very good background that she has provided that actually sets the tone for the discussion that I'm just going to take us through over the next couple of minutes. So just a general introduction to the program and some of the national, county, and facility experiences in terms of implementing IPC interventions. I know it is always very easy for us to document and put down on paper what needs to be done. And working on this and looking at it from the perspective of translating what is on paper to action, what are some of the challenges or what are some of the successes that we can actually be able to achieve even when we have limited resources. So I'll be sharing some achievements and some challenges and what we also think is a way forward in terms of implementation. So of course, maybe this also reflects the situation in many countries where our infection prevention and control systems are still maturing in terms of trying to estimate the burden of healthcare associated infections in our health facilities. This is largely due to lack of national data. And again, apart from just understanding the burden of HAIs in our facilities, the aspect of knowledge on infection prevention and control is actually suboptimal at all levels of the healthcare system. And I think as we went through the discussion earlier by Michelle, we can actually be able to appreciate the vast nature and the diversity in infection prevention and control. And also just understanding that from a country perspective, our past infection prevention and control efforts really focused on injection safety and medical waste management. And when we interact with a lot of our healthcare workers, they actually get to realize that infection prevention and control is actually beyond injection safety and medical waste management.
I can't hear now.
Can you hear me?
The sound is completely gone.
Hello, can you hear me?
I can hear you.
Great.
I'm not sure everybody can though.
I can hear you as well.
Okay, great. Thank you. So looking at our organization at the national level, this is a fairly young unit or division within the Ministry of Health, established formally in 2014. And the patient safety unit, which is now a division within the Ministry of Health, runs 3 programs: infection prevention and control, antimicrobial resistance, and we also have patient and health worker safety. So this is how we are organized. We actually fall under the Directorate of Health Standards.
I can't hear.
We actually within the Directorate of Health Standards, Quality Assurance and Regulation. And like Michelle said, some of the programs will be positioned in different areas in different countries, depending on how countries have actually structured their ministries of health, Department of Health. This falls under the Quality Assurance Regulation because we have actually positioned infection prevention of and control as a key component of quality of care. and a key component that is required to be in place for patient and health worker safety to be achieved. So that is how our infection prevention and control program and AMR programs are actually placed or positioned within the standards, quality assurance and regulations directorate. So because of that positioning within the organogram of the Ministry of Health, we have a national IPC program that has a vision and a mission that is very well stipulated within the national policies. So of course, we envision a health system that's committed to reducing the high incidence of HAIs, and also just recognizing the importance of well-coordinated IPC activities. And like you heard from Michelle's presentation, the roles and responsibilities of the IPC team are actually very many. And in the absence of proper coordination, it is very hard to be able to realize the intended outcomes. So of course, that the vision also speaks to the mission that we want to improve the safety of patients. The clients that visit our healthcare facilities, they are not always patients, but you have clients coming into our facilities for different services. And of course, not forgetting the healthcare workers. Many times we forget about the safety of healthcare workers. And of course, if our health facilities are safe, then the general public will also be safe. So our work is governed within the national IPC policy, which gives guidance to what needs to be done right from the national level to the healthcare facility. And this is actually our third edition of the National Infection Prevention and Control Policy that is due to be launched in a short while. And we have made linkages with critical documents within the Ministry of Health. For example, the Universal Health Coverage Policy, we realize that infection prevention and control needs to be embedded in all the key documents within the health sector. So we have made an effort to make sure that our IPC interventions are within key policies like the Kenya Health Policy and other policies, programs, and sectors like even the TB program. We have made sure that we have active linkages within different sectors in the Ministry of Health. So we have identified specific areas that under our policy implementation, like you can see, and we are giving a lot of priority in the face of establishing institutional coordination structures to enable policy implementation. And that is what Michelle has been talking about. IPC committees are actually institutional coordinating mechanisms without which the implementation of the policies or guidelines becomes really difficult. We also take note of the importance of policy, legal and regulatory frameworks that actually enable this work. We also have prioritized funding for IPC programs because we realized in the absence of appropriate funding or adequate funding, then the implementation of some of the interventions that are proposed in our work plans by the committees become impossible. We've also prioritized education and training because we realized we had a big training gap in Kenya. So this is actually one of our priorities. And also the place of supervision. How do we conduct our audits and assessment? How do we feedback to improve the practices? And also now working towards ensuring that IPC goes into our national accreditation frameworks. Then we also have the place of surveillance. Like we said, we don't know the burden of HAIs. So in the absence of surveillance, you will not be able to understand that. Then the place of advocacy, to prioritize IPC and to position it in the place that it should be. So for us during this COVID era, we say the pandemic has actually brought IPC to the forefront, and it's been at the backseat for a very long time. So we need to identify ways of continuing the advocacy, position IPC, and also build partnerships to support the implementation processes. And then we have the research and development and M&E. Our strategic plan has also been updated this year, and this is what now provides us with the actions that need to be taken in order to appropriately implement our policy interventions. So this is how we have positioned or described IPC. We have ensured that within the health sector and in the strategy that IPC features prominently as an element of quality of care and patient safety. And again, it is an important element of occupational health and safety practices in health care settings. And I think we have seen this so much during this COVID era, where a lot of our colleagues have gotten exposed. We've lost some sadly because of exposure to COVID-19. And we're also looking at IPC as an element of environmental health in healthcare settings. So we are now partnering actively with WASH. And again, clinical and public health surveillance. We can't talk about that and miss out on the infection prevention and control. And of course, right now, the aspects of infection control within the community, and also emphasizing the importance of appropriate supplies, equipment, and the relevant necessary infrastructure that is required to be in place to support effective implementation of IPC. So in terms of our coordination structures from the national level to the facility, this is how we are organized. We have the national IPC program, like I said. So the IPC program is informed by discussions and decisions that are made at the National Infection Prevention and Control Advisory Committee, which is a committee made up of several experts and practitioners in infection prevention and control from different levels, the training or educational sector, the medical training institutions, healthcare facilities, partners that are implementing our IPC work, and also colleagues that work within the Ministry of Health. So the National Advisory Committee is further fed into by a group of technical experts who sit in the IPC Technical Working Group. So the Technical Working Group meets more often, draws up the work plans, identifies the priorities for the infection prevention and control program with support from the different members who serve in different capacities. And we have also recommended that at the regional level, because Kenya is, the system of governance is a devolved system. So that means at the national level, policies, guidelines, training standards are set, but the implementation processes happen at the county level and the facility level. So it is important that we also have coordination mechanisms for effective communication. So we have county level coordination mechanisms, and we have our county level IPC advisory committees, and further down sub-county IPC coordination. And at the hospital level, this is where we have our hospital infection prevention and control committees. And the lower levels, which is actually our primary healthcare levels, we just require an infection prevention and control focal point due to the fact that they don't have as many staff compared to the other levels of care. And you can see from the image on this particular slide, we require through the policy that counties officially appoint members to their advisory committees, so that when there's communication and their guidelines to be disseminated, or if there's action to be taken at the county level, they have their own systems that can supervise and provide guidance to the healthcare facilities within their area. And you can see from the representation, you actually have a broad representation of the people that are required. It's not just the nursing services. We have those that are in charge of administration, especially because of the funding requirements, directors of medical services. You have the county nursing officer, the public health officer, the health promotion officer, because of messaging and dissemination of the same. So as you can see, you actually have a wide representation of members who actually add a lot of value in terms of making sure that IPC is mainstreamed and our interventions are implemented. We have also provided terms of reference to the county IPC committee so that they are also guided. And like Michelle pointed out rightly, without clear terms of reference, the committees end up becoming inactive because members don't understand what they need to do. So as you can see, we have put down quite a number of terms of reference for the IPC committee so that they are well guided. Aspects of supplies, ensuring that IPC is covered in their county strategic plans and their annual operational plans for purposes of planning and budgeting is critical and is a responsibility of the IPC committees. Conducting audits and also providing health facilities within their jurisdiction with appropriate documents or reference materials for IPC. Of course, ensuring ongoing on-job education is important, and just being there to advise staff on what needs to be done. And we are responding to the current pandemic, supporting the investigation of the spread of infection if you have outbreaks, and this is done in collaboration with several teams in the facilities and the counties as well. So moving from the county level, the facilities are also further instructed, because this is also what is mentioned in the policy, that after the county has established its own prevention and control advisory committee, the facility needs to appoint their institutional members to the IPC committee. And we have found this appointment so important because it gives the members a sense of ownership and authority and mandate within which they require to be able to fully commit to their work and fully commit to achieving or implementing the terms of reference that have been given to the different committees as depending on the level of care that they are in. So when we had committees that were just verbally constituted, we had problems getting IPC committee members committing their time and effort to IPC work. But when they received an appointment letter officially, it gave them the confidence and the authority to fully participate in committee deliberations as well as the implementation processes. So what are some of the achievements that we've been able to see as a national program? Of course, the establishment of the IPC program at a national level is a big win because it allows you to actually put together a lot of the IPC work and disseminate this in a structured way, and also get support partners because you have policy documents and you have strategic plans that you can actually use to provide guidance in terms of investment and interventions. So this has helped us even in profiling and positioning IPC now as a policy agenda in the health sector. And because of that, from a national level, we've been able to successfully develop an IPC training curriculum, which is like a 6-day training course. And because of the need and the interest to build our own IPC practitioners within the country, we're currently just finalizing the development of an MSc course in hospital epidemiology and infection prevention and control, because we need to start defining IPC as a career. So developing the career pathway for infection prevention practitioners requires a robust training and education level. So we've also been able to establish IPC programs at the county and facility levels, at least for all our 47 counties. We have infection prevention and control focal points, and now activating the IPC committees. So we also do the dissemination of guidelines. We have developed facility IPC assessment and audit tools, which are being used at the county and facility levels. And in terms of regulation, so that you also have sustained implementation of infection prevention and control practices, we have included our IPC standards in our joint facility inspection checklists and also our Kenya quality model for health. So wherever standards are required to be developed, we have tried to be proactive to make sure that some of our basic standards actually make their way into national documents that are broader and have a wider impact in terms of implementation. And of course, we also have an infection prevention association, which is our IPNET Kenya, which has augmented the work of the national structures in a great way, because this association brings together all cadres within the health sector and allows them to discuss or deliberate on IPC issues on the same platform. We've carried out a lot of training. We've identified a mentorship model for our healthcare facilities. We started off with 2 sites, but because of the success we saw, we are currently scaling up our CQI approaches for all the facilities that we are beginning to support. And as a result of mentorship, we are seeing a progressive emergence of champions and success stories at the county level. So this is just a facility and county assessment that I would like to share, just to also augment what Michelle said earlier. Without an assessment, a healthcare facility might not know that they have challenges. So we went into this facility and a county, of course, at the beginning, and we realized they had inactive IPC committees. They also didn't have a full-time IPC coordinator, despite being a facility with more than 250 beds. They didn't have policies and procedures in place. And of course, in the absence of an active program, it's very hard to have policies and procedures in place. And definitely when you have no procedures, of course, audits are something that doesn't come very often to the conversations. So when we carried out our baseline in this facility, the hand hygiene compliance at baseline was 23%. And we needed to begin to engage the IPC committee. Why I'm saying this is because the availability of local data is so important to drive the effectiveness of an infection prevention and control committee at a facility level. Without data, the IPC committee has very little that they can be able to act on. So we analyzed the root cause of the inactivity of the program. So we realized they didn't have formal appointments. We also analyzed the causes of low hand hygiene compliance. And we went through a process of root cause analysis and used a cause effect diagram, and we were able to identify the reasons why the program was inactive and why hand hygiene compliance was low. And I just picked out one aspect out of several areas of assessment which we conducted. So the facility, because now things were beginning to come together, formally appointed the IPC committee, which is one of the pictures that you can see here. The IPC committee reviewed their assessment report and went through a training on infection prevention and control, and we realized many of the committee members had not been trained on IPC. And after the training, we went into a CQI process, continuous quality improvement process, and had a very intense root cause analysis to all the problems that they had identified during the assessment. And using this root cause analysis, they were able to come up with actions. And you can see it meant so much for the IPC committee to have an aim statement, what to see at the end of a specified period. And for us, the advice was start small. What can you achieve so that when you see the success, then you're motivated to even do bigger things. So they were able to identify the drivers. They drew a work plan from the gaps and what they had identified. And they set a target for themselves. So this was not a national target, but it's a facility-driven target led by the IPC committee. And they started quality improvement interventions on their own. They had sessions to feed back to their hospital management teams on the baseline data. And most often than not, the HMT actually was surprised by the data. And they conducted CMEs also to other healthcare workers because they pulled out hand hygiene as one of the areas they wanted to work on. They carried out an audit of basic things like the functionality of hand washing sinks in the hospitals because they realized this was a barrier. Some of them were non-functional, so healthcare workers could not wash their hands. And they ended up sharing the audit report with the director of the hospital. And it was good because the repairs commenced immediately. So we are saying this because some of the findings that the IPC committees bring to the surface actually have immediate actions. And they continued with monthly data collection and feedback, not just at a hospital level, but to every department on progress. And we had mentorship sessions with our implementing partner and the facilities to share how they could further improve their hand hygiene. We realized one of the facility had connectivity challenges, and through our partnership with some of the implementing partners, they received a video conferencing machine to enable them to connect to our virtual mentorship sessions. Initially, it was the whole committee with one laptop, but with the support of the implementing partners, this was upgraded and we had better interactions. So you can see these two hospitals were our pilot hospitals, and every 2 weeks, we had a session to discuss hand hygiene data over a period of more than 2 years as the facilities built their simple hand hygiene programs. And you can see they had results, the campaigns, and you can see compliance rose from 23% from May to September. They had already crossed their target. So what I'm saying is when the IPC committees at the facility level are well-directed, clear terms of reference, simple work plans with targets that are achievable are set, then you can begin to see improvements that are made, and you can see success in the implementation of different interventions. And you can see even basic things that can change overnight. This was in one of the wards. Before the assessment, they had a bar soap that they were using for hand hygiene. But the following morning after assessment, they had already put liquid soap in an improvised bottle, and this was available. So you can see just what an assessment or a support supervisory visit can do in terms of improving implementation of infection prevention and control at the facility level. Same here, just basic things like neatness of our trays in the different wards that we work in. support supervision, data collection, and sharing and giving feedback goes a long way in improving practice. So what we have realized as we supported the response to COVID-19, we had an advantage because the national IPC program was already in place. So we evaluated, we had a national policy, we had champions at different levels. We also had TOTs on IPC across the country by the time COVID hit. And we also had an increased capacity building initiative by many of our partners. And again, IPC was not just being handled in one area. Within the National Action Plan for Antimicrobial Resistance, it's one of the objective areas that is being handled. And of course, the existence of the coordination mechanisms at all levels also made it a bit easier for us to intervene during COVID-19. And because of those trends, at the onset of the pandemic, we were able to quickly develop and update appropriate guidance. We provided SOPs, we provided training materials because we already had a training course. We also provided IPC materials, not just for the health sector, but also the non-healthcare setting. So we influenced discussions in the education sector, for security in the hotel management industry. So it gave us an opportunity to reach out. And of course, just by training healthcare workers and supporting further institutional capacity building, using assessments, we were able to conduct assessments of about 900 healthcare facilities and use the findings to further strengthen infection prevention and control, and also identify areas that required more training and also work on a compliance tracking mechanism. Of course, there are challenges, and like many of our countries experience, the IPC programs are under-resourced at all levels. It's not just the facility level, but even at the national level and the county level, this is one of our biggest challenges. And how do you enforce IPC guidelines? Of course, the legal and regulatory frameworks are still not supporting compliance to infection prevention and control. So this is something that is work in progress, and we hope that when the legal frameworks are in place, it will be better coordinated and we'll have better compliance. The challenges of rolling out interventions because of the gaps in enforcing the policy and guidelines remain a challenge. We have very good guidelines, but when you go to the facilities, the implementation is different. Either management doesn't understand or health workers have not been trained, so they don't know exactly what to do. So the rollout of the interventions at a scale,